Now the speaker is Dr. Michael Fehlings. Can you please unshare your screen? I will share the screen because he has done a recording, and I will play his recording for this talk. His talk is the Time is Spine translational update on approaches to facilitate repair and regeneration of the injured spinal cord.
Hello, I'm Michael Fehlings, professor of neurosurgery at the University.
Good, we hear that.
Pleasure to take part in this update of spine surgery, with a focus on spinal cord injury. I'll be talking about translational approaches to facilitate repair and regeneration of the injured spinal cord, with a particular focus on neuroprotective and neuroregenerative strategies. I have no disclosures that directly affect the content of the talk, but I'm actually pleased to disclose that I have spun off a biotechnology company that is moving regenerative therapeutics forward, and this is being handled at an arm's length from myself. And I wish to acknowledge the organizers of this session, who are acknowledged on this slide. Just to frame the discussion, I present this case of a young individual with a bilateral facet dislocation as a result of a diving injury, a serious Asia A C4 cervical cord injury. So what is our treatment approach in the modern era? And I'll be talking about neuroprotection. I'll be briefly presenting the concept of early decompression, and I realize that Wilco Poole will also be making reference to this, but I think this is important to establish this because part of the time of spine principle when we consider neuroprotective and neuroregenerative approaches will relate to the optimization of the milieu for recovery. And then I'll be specifically talking about the Riscus trial, focusing on riluzole. I'll be touching then on regenerative approaches, methods to bypass injured neural circuits, and then I'll conclude with some comments on where we are now and where we are going. So time is spine, and early neuroprotection mitigates secondary injury mechanisms and enhances outcomes. And this principle guides surgical and pharmacological approaches for acute spinal cord injury. And there's a strong rationale to consider the concept of early surgery as a method to try to mitigate the secondary injury consequences, which are exacerbated by the ongoing compression and instability related to the fractured spinal column and compression of the spinal cord. So just by way of review, the results of the STASCA study over a decade ago provided strong proof of concept for the impact of early decompressive surgery done within 24 hours. And this study showed that the odds ratio of achieving a 2 or more grade change in the Asia impairment scale with decompression done within 24 hours was almost 3-fold higher than control. Based on this, the first practice guidelines were initiated in 2017 in the Global Spine Journal. And for the first time, these suggested that the optimal strategy was early surgical intervention within 24 hours. But the evidence for this was weaker than we would have liked. And as a result of this, we undertook a number of studies. And in fact, since the issuance of those guidelines, a total of 17 papers have been published that further strengthen the concept of time is spine. This is our work from Lancet Neurology, meta-analysis in over 1,000 patients, showing a dose-response relationship between the changes in neurologic function and the timing of surgery, with the optimal improvements occurring within this 24-hour time window. And this plot here shows that the most significant improvements in motor function occur within this 24-hour time window post-surgery. So based on this, we felt that it was necessary to update the guidelines, and I'll be making a reference to this in the next few slides. And Dr. Poole will be making reference to other knowledge gaps and concepts related to the role and timing of surgery. In the next couple of months, the AO Spine Praxis guidelines in spinal cord injury will be coming out in the Global Spine Journal. And this is a synopsis of the meta-analysis related to the role and timing of surgery for acute spinal cord injury. The top forest plot shows that if surgery is undertaken within 24 hours, one can anticipate a mean improvement in the motor scores of around 4.5 to 5 points. Particularly for patients with a cervical injury, this could represent a fairly substantial improvement in upper extremity strength. The lower plot confirms that early surgical intervention is associated with significant shifts in the likelihood to achieve a 2 or more grade improvement in the Asia impairment scale. And essentially, these results validate and confirm the results of the STASCUS study. In addition, there are economic benefits to early surgical intervention, for example, by the reduction in hospital length of stay. Now, importantly, the SkyPoem study from Europe was published a few months ago, and these authors attempted to validate the role of ultra-early surgery in comparison to later time points. One of the challenges that the authors did encounter, however, was that due to shifts in practice patterns, most patients in the delayed intervention group actually had surgery within 24 hours. Now, the unadjusted analysis did show improved recovery in the lower extremity motor scores, which just missed significance. There were significant baseline differences, however, in the ultra-early and early groups, and there was a significant loss to follow. So as a result of this, I would interpret this study as showing potential proof of concept for the role of ultra-early surgery, but this will require further confirmation. So this is the guideline statement related to the role and timing of surgery for acute spinal cord injury that will be coming out. And there is now a strong recommendation that surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours after injury when medically feasible. Now let's just briefly revisit the role of corticosteroids. And I would issue the recommendation that corticosteroids be considered an option, particularly in patients with a cervical injury, patients who are not medically frail, and patients with an incomplete spinal cord injury. So we undertook, through the AO Spine Practice Guidelines team, an independent analysis of the role of methylprednisolone. And this was undertaken by an independent statistical group through Spectrum Research in Seattle. And based on this meta-analysis, Spectrum Research confirmed that there was, in fact, a modest benefit of corticosteroids of between 3 and 4 motor points. Now, it's important to personalize this approach because a patient, for example, with a severe thoracic spinal cord injury may not derive a functional benefit from such a neurologic improvement, whereas patients with a cervical injury could have substantial benefit in upper extremity function. Importantly, the risk-benefit ratio of corticosteroids is actually favorable. And in fact, there is a trend toward a reduction in mortality with corticosteroids. And realistically, with modern intensive care protocols, the side effects of corticosteroids can be readily managed. So based on this, it's felt that intravenous methylprednisolone after spinal cord injury is a valid practice option, and I would particularly recommend its use in non-frail patients in patients with cervical injuries. And this is the publication that emerged in the 2017 Clinical Practice Guidelines in the Global Spine Journal. Now, where are we going with this? And I want to present the results of the recent RISCUS randomized controlled trial, which was published in the Journal of Neurotrauma as part of this focus issue. So what is riluzole? Riluzole is a sodium channel blocker that reduces the release of excitotoxic glutamate following traumatic spinal cord injury. In the clinical realm, this has been widely used in the treatment of amyotrophic lateral sclerosis. And notably, riluzole is without potent neurotoxic or cardiotoxic adverse events. Prior to undertaking a large phase 3 randomized controlled trial, we undertook this a preliminary phase 1/2A open label trial that was published with the collaboration of Dr. Robert Grossman in the North American Clinical Trials Network. And in this study, undertaken in 72 patients, we found that there was a clinical benefit based on conversion of the ASIA grades, and this was favoring riluzole. And if we looked at patients with cervical injuries, we saw that there was a favorable trend for improvements in motor scores. So based on this, we designed a phase 3 randomized controlled trial called RISCUS. This is undertaken in Canada, the United States, and Australia. The patients were randomized to receive riluzole or placebo, and riluzole or placebo was administered within 12 hours after traumatic cervical cord injury for a total of 2 weeks. Primary endpoints for total motor scores or upper motor scores. Secondary endpoints are listed here, and these included such variables as the ASIA grade, spinal cord independence measure, SF-36, and neurological level change. These were adults between 18 and 75, and we excluded patients with a significant traumatic brain injury. Now, unfortunately, we had a substantial challenge with the COVID pandemic, and ultimately we halted the trial as a result of the coronavirus issues. Nonetheless, we were successful in recruiting 193 patients into this randomized trial, and this is the largest randomized trial of a neuroprotective drug that has been undertaken in 3 decades. You'll see the shifting demographics of traumatic spinal cord injury, the median age of almost 50 years of age. Importantly, most of the patients actually had a cervical ASIA A spinal cord injury. And at first glance, this might be a bit of a surprise because the commonest phenotype of spinal cord injury that we're now seeing is cervical ASIA C. And I suspect that this reflects practice patterns where patients with very severe injuries tend to be medically prioritized for transfer and early surgical intervention. But this certainly biases the results against a potential protective influence with a drug such as riluzole. Now, because of the impact of the coronavirus pandemic, our sample size was lower than was initially planned. Nonetheless, we did see beneficial effects of riluzole compared to placebo, which just missed statistical significance. These are the forest plots with the means and 95% confidence intervals. Now, over 4,000 trials were halted as a result of the coronavirus pandemic, and the Conserve 2021 statement indicated that for severe conditions such as spinal cord injury, increased attention should be paid to secondary endpoints. And this is, in fact, now what's been done. So for ASIA A patients, we found that there was an improvement in the neurological levels. For ASIA B, we saw multiple significant improvements, including the total motor scores, as well as the spinal cord independence measure scores. And importantly, the most striking beneficial effects were seen in the patients with cervical incomplete injuries as characterized by the ASIA C phenotype. So these are the results of the multivariate linear regression. These are all of the patients, and these are the means and 95% confidence intervals for the total motor scores, upper and lower extremity motor scores. And you can see how closely we were to achieving statistical significance for all patients. For the ASIA C patients, we saw a statistical significance, which was clinically very interesting for the total motor scores, upper extremity motor scores, and lower extremity motor scores. Importantly, the safety was excellent without any serious adverse events. So in summary, 193 patients enrolled, and while the primary efficacy analysis did not reach the pre-specified criteria for superiority, there was a positive signal in several pre-planned secondary analyses in the ASIA E, A, ASIA B, and ASIA C patients, with the most striking benefits seen in the ASIA C cervical patients. In parallel with this, we ran a pharmacokinetic, pharmacodynamic study, and we also looked at biomarkers. And importantly, riluzole was associated with a reduced breakdown of phosphorylated heavy chain neurofilament. indicative that riluzole was protective against axonal degeneration. So in summary, I would present riluzole as an option to be considered, especially in patients with severe incomplete cervical cord injury. And my hope is that clinicians will consider the use of riluzole and to examine this in prospective fashions. Now, from the perspective of neuroregeneration, I'll comment on this briefly. And this is an image, photomicrograph of a chronically injured cervical cord with myelomalacia and the surrounding perilesional scar. This is clearly a hostile cellular environment. And trying to address this, regenerative strategies are required to target these barriers. So for time's sakes, I will just briefly summarize some of these approaches, which include targeting inhibitory molecules such as NOGO, RGMA, as well as strategies to try to address a perilesional scar and the changes in the extracellular matrix. There are intensive efforts on stimulated endogenous stem cell regeneration, and it is anticipated in the next 2 to 3 years there will be a new wave of trials with exogenous neural stem cells. And to complement this, there are regenerative rehabilitation strategies, including the use of electrical stimulation and brain-computer interfaces. So this slide just summarizes some of the work being done with the network chaired by Armin Kurt. And this is a translation of Martin Schwab's seminal discovery of the NOGO-A inhibitory molecule. And in these trials, Kurt and colleagues are examining the use of monoclonal antibodies to target NOGO. It's anticipated the results of these early phase trials will be released later this year. And this slide briefly summarizes some of the outstanding work from Harkema and Edgerton in the United States and Courtine in Europe related to the use of electrical stimulation to stimulate the locomotor central pattern generator, as well as with brain-spine interfaces. So where are we now in 2024? I would argue that time is fine and that early surgery for spinal cord injury has become the standard of care as soon as possible, but within 24 hours. Hemodynamic optimization is important, but we need better evidence around the optimal targets. Methylprednisolone is an option, especially for cervical injuries in individuals without medical comorbidities. And other neuroprotective options are emerging, and I think riluzole is an attractive target, and there's intensive work that's undergoing with active targeted rehabilitation and the electrical stimulation to activate neural networks. So where will we be in a decade from now? My hope is that early surgical intervention for spinal cord injury will become an international standard of care, including in low and middle income countries, and optimal techniques, including the potential use of duroplasty, will need to be validated. My hope is that several neuroprotective options will be in the clinic for clinicians to use, and that personalized approaches to individualized care, for example, the examination of genetic signatures, will be increasingly applied. I anticipate that hemodynamic management will be optimized potentially through techniques to assess spinal cord perfusion. My hope also over the next decade will be that a number of regenerative options for spinal cord injury will become available, including the use of neural stem cells, bioengineered options, and the targeting of inhibitory molecules. And I envision that we will have a better handle on how to best apply electrical stimulation techniques and brain-computer interfaces in concert with advanced approaches for targeted rehabilitation. And just by closure, by way of additional reading, we have a couple of books that have recently come out related to degenerative cervical myelopathy, as well as a traumatic spinal cord injury. Thank you.
Yes. You can unshare the screen. Yahya, you can unshare.
Yes.
Okay. I thank Michael Fehlings for a very nice overview of the current condition of regenerative and medical therapy options. As you can see that there are still some experimental options. They are not standardized yet These are stem cell therapy. Even riluzole is not a standard therapy. And what we have in hand actually is the hemodynamic stabilization of the patient and a very good intensive care unit. And only in the younger patients with no comorbidities, we can try high dose methylprednisolone. There was one question, I think. I can answer this question. What is the dose of methylprednisolone recommended and for how long? That AO spine study is recommending just for 24 hours, starting with 30 milligram per kilogram bolus injection in 15 minutes, and after that, 5.4 milligram per kilogram IV infusion per hour. But since that treatment has many complications like gastrointestinal complications and others, it is recommended only for young patients. Are there any other questions or comments? We'll go.
I think, well, I want to support what you are saying, and Michael was saying it too, that methylprednisolone only should be selected for those patients which are so-called healthy, but after trauma, you're not healthy anymore. So I'm very curious what he does do with the multi-trauma patients, if there's, besides spinal cord injury, also blunt abdominal and thorax trauma. Because I think the risk of methylprednisolone is also there, because we can see more infections in those patients. So Michael's very convincing when he talked it, and I discussed it also with him recently in Cape Town, but I think the evidence is not that clear. It might also be difficult to prove methylprednisolone because every patient is different, and maybe in the future we can have selected so-called healthy patients. But I don't think that a lot of people in my area use methylprednisolone anymore.
Yeah. Michael Fehlings could not join us now because he had a surgery now. He couldn't join us, so he will not be able to answer the questions. But there is one question for me and you, Wilco. Are we using high-dose methylprednisolone in spinal cord injury? What will you say, Wilco?
Yeah, and I think the question around it is, what is the selected patients?
Yeah.
And I think the selected patient is a young patient, but I'm also young. I feel still young, but completely healthy. So if you have healthy patients before the trauma, without any blunt thorax and abdominal trauma, those patients might be able to receive it. But that's the opinion of Michael. In my clinic, we don't use it because we don't believe in it. And the other thing is, I think that Michael is right, that we should do further studies to prove what is happening. And the same is true for the RCT with the riluzole. There seems an effect, but I cannot buy riluzole in my country. So that's also a difficulty.
Yeah.
So what do you think, Mehmet and Enrique? Is there optimal patient?
You may remember we have also discussed those issues during WFNS Spine Committee consensus meetings, and we already endorsed what the AO Spine recommended. The guidelines, we endorsed them, and it's my idea. So if the patient comes in the first 8 hours, and if the patient is younger than 45 and no comorbidities, we can give some drugs, methylprednisolone, as I mentioned before. But if Otherwise, for the patients coming later, it is not necessary to give any methylprednisolone.
Yes, I think that until now there are not really a good validation of the use of methylprednisolone, and like Wilco say, it's very difficult because you have a very young people with health, very good health, but normally these kind of people came with another polytraumatic lesions and abdominal, and it's very difficult to have a patient with this characteristic, only with a lesion of the spinal cord, important lesion, and to come very early and not have another problems with the trauma. It's very difficult to find this kind of person, and for that reason is very difficult, and for that reason we don't use it.
Another question is by Dr. Adrian Azamfirei. Any progress with stem cells? We understand from from Michael Fehlings' talk, there is no standard therapy options yet with the stem cells. What do you think, Wilco?
I think I know that some patients from my part of the world, they go to your country to get stem cells, and to China. So, but there are no good studies yet. But it feels good that it might be reconstruct the spinal cord, but it's very difficult. Well, it might be very difficult too. So I think it's still risky. But if there is a good platform for stem cells, for instance, look at what has happened now in the kidneys. So they can now make a new kidney by stem cells, which is quite interesting. The spinal cord is, I think, a little bit more difficult than a kidney. But maybe I'm thinking too difficult about that.
Eric, what do you think?
Yes, I think that there is very, until now is not really no demonstration. I was involved in a trial with a group of Portugal of Carlos Lima 10 years ago, and we take out the cells from olfactory mucosa with the have-sheeting cells and also neurons, and we made in chronic and complete lesions in the spinal. And the problem, of course, is the scare, and we take out the scare of the trauma and put these cells, of the olfactory mucosa. And I operate around 12 or 14 patients, and we have the possibility to improve 1 or 2 levels in the middle of the patients, and also in 3 of these patients recover some control of the sphincters. But really, the possibility today to have with the stem cells and other things are really not in function until now.
Yes. Yeah, thank you, Enric. Dr. Sashi Wathanan want to ask. You can unmute, Doctor. You want to ask something? Please unmute yourself and ask your question. Any research going on in stem cells with nanoscaffold technology? I don't know. I have no idea. I find all the stem cell studies still in experimental stages. They are not
Professor Zileli, I can say something. So we have some paper with this issue. We have some experimental study with nanoscaffold. We made some nanoscaffold and we put in the spinal cord in rats, and we put stem cell in nanoscaffold, and we give some electrical stimulation at the same time in rats. We see some good results, but it is not suitable for clinical use. But some of clinical trial I know in Japan, they are making some again nanoscaffold, and they are trying to put in clinical use.
Thank you, Yahya. There is one more question to Wilco. The doctor, sorry, you are asking, Yahya.
Yes.
Yeah, you can tell it here.
Yes, I wanted to ask the Professor Wilco. Sometimes we can see some cervical fracture dislocation with severe head injury, and we need to make operation to cervical area, but we see some brain injury, and there is no big hematoma, but there is a very severe edema in brain. And how was your management to these cases, Professor Wilco?
Well, if there's a severe dislocation and there's brain trauma as well, if you can, if we can do in our clinic, if we can do anterior surgery without the patient turning around, then that would be preferred option. And to delay the posterior surgery to at least 1 to 2 weeks after the brain trauma treatment. So in my clinic, we do the anterior surgery. If anterior surgery is not possible, but mostly it is possible. But if it is not possible, then we have a very difficult dilemma. I had a patient where I did posterior surgery and had massive edema after surgery and had to do a bilateral hemianectomy to solve it. The patient survived, but I think that I made the patient worse by doing the patient in a prone position. And I think this is a very valid question because we are talking about big populations and research, but mostly those patients are excluded from studies. And maybe we should include that.
Yes, thank you.
Right. Another experimental thing, although there are also some human studies, they are not high quality studies about the electrical stimulation of the spinal cord, dorsal cord stimulation. So we experienced similar things, similar practices in our environment. Who some surgeons are recommending the patients, complete spinal cord injury patients, to apply dorsal cord stimulation.
Yeah.
What do you think about this, Wilco?
I think it's very promising. The research group in Switzerland, Lausanne, is very active on that. So these brain-computer interfaces and spinal cord
This is something else, Wilco.
Yes,
This is...
yeah, but they have two schools. So there's a brain-computer interface and a spinal cord stimulation.
I know this. This is okay, but they are stimulating spinal cord distally. What I'm telling, and then trying to make a good interface with the brain, so that the patient can control with by using his brain waves, can control the lower limbs. This is something else. This is, I must call it, a functional electrical stimulation. In the past, the researchers were using muscles only for stimulate. Now they are going up to the spinal cord, distal spinal cord, however, and then trying to stimulate that level, or sometimes the peripheral nerves. But what I'm telling that stimulation of the rostral spinal cord above the injury level. That may modulate the function, lower extremity function. This is an experimental thing, and I have even seen some pain physicians are doing that because they are able to insert electrodes, transcutaneous electrodes in the upper spinal cord levels, and then they stimulate it, and then they say it is very useful for spinal cord injury.
Oh. And those are physiotherapists doing that?
No, they are pain physicians.
Oh, pain physicians. So anesthesiologists probably.
Anesthesiologists,
Wow.
yes.
Yeah.
I'm
Wow.
telling this. There are some studies even on that,
Yeah.
but this is something else. This is not electrical stimulation. This is dorsal cord stimulation. So this is the spinal cord injury is a subject that can
Yeah.
be abused easily by many other medical sectors, and it's not good actually.
I think the good thing is that there's a lot is happening in spinal cord injury, whereas years ago the patients were left alone, and now the only things we have worldwide to control what is happening. So if those experiments are now happening, those they should be done with a clear ethical view, and it's a research question because these patients are very skeptical for hope. They think they get a hopeful treatment, but they don't know about the risks. And I think it sounds interesting that with electrical stimulation, you can cross it. The same for stem cells, the same as all the studies that Michael is doing. I think it's very important that not only Michael is doing those studies, but also other parts of the world. We try to find a solution for the next decades for our future patients. So I'm very hopeful. And every time you see in every disease in the body, innovation comes first. And then the people who innovate should be helped to do clinical research. So there's a big gap between basic science and clinical work. And we have to cross that. And I think that's good news.
Good.
Yeah.
Would you like to tell something, Eric?
No, I agree completely with the problem is very difficult to resolve until now, and no solution. But this electric will be a very interesting thing for research.
Yeah. Yahya, you want to add something to our discussions?
Thank you for all the speakers. It was a very useful.
There are two questions. One of Radotino Tony.
Okay.
Do we have data on the fate of the patients operated on who had respiratory problems? Well, we do know that respiratory problems in the acute phase might be very harsh and difficult to treat, but you have to let the patient have some time to get a recovery. Sometimes people stop too early the ventilator on patients, and it's very dangerous in the acute phase. So I think that I don't know what the opinion of the other people is, but in the very acute phase, in the spinal shock phase, and neurogenic shock phase, you should not decide on breathing or not, unless you don't have ventilators. So that's
are you using, although rarely probably, but are you using any phrenic nerve stimulation?
No.
It's a very rare indication probably.
Yeah.
Maybe I can say some things. We have some patients like that after cervical spinal cord injury. There is breath problems. Thoracic surgeons make some operation for phrenic smear stimulation operations.
Okay.
It helps to them for give up respirator, home respiratory systems. It helps.
Yeah. That's a good idea to do that.
Yeah. Okay. I think we can finish our session. I thank a lot to Dr. Enrique Osorio and Dr. Wilco Poyle for their very nice talks, and Michael Fehlings for giving us the opportunity to present his talk, but he couldn't join us during the discussion. I wish to see you in future meetings.
Thank you, Mehmet. Thank you, Mehmet, for all the organization together with Yahya, and also to let this IAS fly so that the spine community lives again. So thank you very much for your for leadership in this group. Thank you.
Thank
Thank
you.
you, Mehmet.
Wish
Thank
to
you,
see you
Mehmet.
again. Goodbye.
Very good organization. Thank you. Bye-bye.